So I get this, I look at my assignments, I'm like, no more boundaries for TAVR. I have no idea what that means. So, but the good news is, well, I guess then you just get the world according to Greenbaum. So here are my disclosures. So I don't know, when I thought about this title, I said, all right, well, what were the boundaries to TAVR, right? There was an issue with invasiveness. These are historical things. There were access issues, particularly for those who didn't have good femorals. Was it really safe for those who were lower surgical risk, right? Stroke, coronary obstruction, things like that. Was it efficacious in these certain anatomies, like calcification bicuspids? And were they durable in those with longer life expectancy? And I want you to just remember why I wrote longer life expectancy. All right, so let's tackle these one at a time. Some of this we can blow through because a lot of the things have already been touched on actually by Alan and David, but okay. So, moving from where we all started to a simpler case. There's data out there that it is equally safe to do this minimally invasively, and it's equally safe to discharge people early, okay? So this boundary of invasiveness is gone. If you're not doing this, you got to think about why, right? No more intubation, no more catheters, no more art lines, no more intubation. Get them home the next day. In fact, I'd argue you'd probably get these people home the same day. That is coming. All right, what about the second issue, access? We know if you really push the femorals, things don't go very well. We also know, why am I not moving forward here, guys? Here we go. We also know that the intrathoracic access methods have some issues, right? If you propensity match people, they don't do as well. So what do we know about the extrathoracic methods? We have data out now over 1 year on the trans cables that there are absolutely no late complications from these procedures. Survival is good, and all of these tracks close. We have data on the subclavians that in the core valve experience, it's equal to transfemoral if you propensity match these people. From the TVT register S3 data, with the exception of maybe this stroke risk, it's better than intrathoracic access in all outcomes. So in 2009, if you don't have good access in the femorals, you got to be picking one of these, right? That's boundary is gone. The only reason I have a question mark about intravascular lithoplasty is there's a little bit less data, but I'm sure it's coming. Okay, TAVR and low risk. Alan showed you this data. Low risk patients, composite endpoints, clear reduction in death, and I don't know why we are not rolling forward here, guys. Okay. If you look at the core valve data, similar, right? If you stack up the composite endpoints, clear reductions in stroke mortality. So in 2019, this is a preferred strategy now for low-risk patients. That barrier is now gone. You saw this slide already. What about the high-risk patients, right? Stroke was 1% or less in these low-risk patients, but if you go back in time to the high-risk patients, it was clearly higher. I think there's evidence that David showed you that these devices do reduce strokes. You could argue about p-values and things like that, but if you want, you can handle the stroke risk for those of higher risk, and you can think about an algorithm on who you want to use it for. So the stroke risk, taken care of, not a boundary anymore. Coronary obstruction, we know it's bad, devastating outcomes. We have a solution, right? Novel approach, directly take care of the issue, split the leaflet. The 30-day results of a prospective study, as Alan showed you, pretty good results, pretty good safety signal, and it does its job. There were absolutely no coronary obstructions and no emergent interventions. So I think we have coronary obstruction tackled. And there is some very interesting bench research that you get increased flow in both the neosinus and through to the native sinus. So we may actually be even in some way have a solution for thrombosis and leaflet durability. Bicuspids, you saw some of this data. Pretty good results these days with newer generation valves to suggest there's no more boundary for bicuspids. And there's probably things you could do to further improve, just as a proof of concept. We have split a bicuspid valve to see if we can more circularize the valve and get better EOAs and better outcomes. More on this topic, but nonetheless, the bicuspid boundary is probably gone. So what are we left with? What about the large annulus? Here's one I did not that long ago, 760, perimeter of 98, 99, with a big leak at the end despite 6 millimeters extra on an S3. What about heavy calcification? Well, if you thought that that was not a boundary, if you look at the P3 study, it took 1,500 patients were screened to get the 1,000. So 34 were excluded, and 20 of them for anatomic reasons, a lot of which were heavy calcifications. So I don't think we can quite use the low-risk studies to suggest that we've handled heavy calcification. And then let's get back to that last topic, which was durability for those with longer life expectancy. Don't confuse low surgical risk with longer life expectancy, right? In the PARTNER 3 study, average age was still 73, and in the low-risk Evolute study, 74. So remember, younger age is not longer life expectancy. You could be young and very sick, right? And you can be old and you can have low surgical risk, but not necessarily longer life expectancy. So when you put this all together, in 2009, where are we now? Just about every boundary's been removed. So I would say mostly no more boundaries. What I think is left, very large annuli. I don't think we have tackled that yet. Sometimes you get away with it, sometimes you don't. Heavy calcification, we just don't have the data to support right now. And then again, for patients with true long life expectancy, we just don't have the data yet. Thank you.